our last video, we finished up our intrinsic hemolytic anemias, which were all intrinsic to the red blood cell itself, so some kind of formation defect, right? Spherocytosis with spectrin or some other protein, G6PD with the missing enzyme, another missing enzyme, pyruvate kinase deficiency, PNH where you're missing either the GPI anchor or you're missing the membrane inhibitor, right? And then sickle cell and HBC where you have a mutation in the things making the chains. Now, the next page goes on to extrinsic hemolytic anemias, which first talks about autoimmune hemolytic anemia, where something caused you to make antibodies that are going to go ahead and attack your own red blood cells, right? So in autoimmune hemolytic anemias, they first have this picture right here, right? And I wish I could make the picture they gave bigger, but this is pretty much it. What you're really seeing here is that all the red blood cells, they're kind of sticking together, right? So you can clearly tell, like, this is all clumped up in the middle right there. So you have warm and cold types of autoimmune hemolytic anemia, and you do need to know the difference between the two. We've already seen cold agglutinins when we were in Mycoplasma pneumoniae in microbiology. Warm is just with IgG. That's really all it initially means. So warm autoimmune hemolytic anemia means that you have IgG attacking your own red blood cells. Chronic anemia seen in lupus and CLL and with certain drugs like alpha-methyl-dopa. I can't remember if I've ever actually seen a question on that, but I have seen questions on the cold agglutinins. So the cold agglutinins, or cold autoimmune hemolytic anemia, is due to IgM and complement. This is acute anemia. So warm is chronic, right? Keep that in mind. Warm is chronic. And you can also remember that in the immunological sense of it, IgG is a thing that's chronic also. IgM is made acutely when you first get sick, right? So cold agglutinins, or cold autoimmune hemolytic anemia, is acute anemia triggered by the cold, which is why it's called cold autoimmune hemolytic anemia. This is also seen in CLL, but you mainly also uniquely see it in Mycoplasma pneumoniae infections and infectious mononucleosis, all right? So what happens in the cold agglutinin stuff is that all the red blood cells, they start agglutinating like this, very much like sickle cells will stick together, right? And of course, just like sickle cell, it's painful. Right? So these agglutinated red blood cells, they will get stuck in capillaries and cause pain, just like sickle cell, right? In sickle cell, you have all the sickled up cells, they all kind of stick together, especially if you're dehydrated as a sickle cell patient, and then they get stuck in various vessels, and you get painful vaso-occlusive crises, right here. So that's a similar kind of thing you see with autoimmune hemolytic anemia too, when all the red blood cells start sticking together. So you can get painful blue fingers and toes with cold exposure. And the reason it happens in the fingers and toes is because the extremities of your body are colder than the central part of your body, especially the fingers and toes, which are usually out, right? Like your fingers are always out. Your toes are in the shoes, but if they're not, if you're wearing sandals or something, or if you're just home and it's cold in your house, then your toes would also be feeling the same kind of agglutination and pain. Now, many warm and cold autoimmune hemolytic anemias happen for no explainable reason, right? So at that point, you just want to look for, basically when you see something that's idiopathic, we spoke about this word yesterday. I was saying how when you say something is idiopathic, that's basically you trying to sound smart, but really just saying that I have no fucking idea why this is happening. It's just happening, right? So idiopathic just means that, to be entirely honest. So if you get a question where it looks like they're talking about red blood cells sticking together, keep in mind that it might be autoimmune hemolytic anemia. There might be antibodies actually attacking your red blood cells. At which point now you have to do a direct Coombs test or an indirect Coombs test, any Coombs test, because most autoimmune hemolytic anemias are Coombs positive, right? So they tell you there, autoimmune hemolytic anemias are usually Coombs positive. So what does Coombs positive really test for? Basically, all your Coombs test is testing for is what you're seeing in the middle right here. This is a positive result. So what you're testing for is when you put the reagent into a bunch of red blood cells, do they all stick together? If they stick together, then you have antibodies on your red blood cells. So how do the two tests differ from each other? In a direct Coombs test, you take the patient's blood, whatever patient came in telling you that they have symptoms that kind of look like autoimmune hemolytic anemia, you take their blood and you give them the antibodies that attack that antibody. Right? So you're basically giving an antibody that attacks the green antibody that's actually attacking the red blood cell. If they have these green antibodies on their red blood cells, then everything is going to stick together. We see how the blue antibody is attacking the green one, and the green ones are all stuck on the red blood cells, so everything is now stuck together. Alright, if nothing happens, if there's no agglutination, that means they don't have the green antibody and it's not Coombs positive. Does that mean that they definitely don't have autoimmune hemolytic anemia? Not necessarily, but there's a very low chance that they might, right? Like, that's very unlikely that they would actually still have it. In the indirect one, what you do is you don't take the patient's blood, right? That's why it's indirect. You do not take the patient's blood. You take the patient's serum. Right? So it's really easy to remember what it means just by looking at the word. Direct is directly looking at the blood. Indirect is without looking at the blood, you just look at the serum. In their serum, they have antibodies against red blood cells. Okay? If they actually have antibodies against red blood cells, then if I add any red blood cells and I add antibodies against this antibody, then everything's going to stick together. Alright? And that's really all that's happening there too. Either way, whichever Coombs test you do, if it comes back positive, they basically have autoimmune hemolytic anemia. Alright, RBCs agglutinate when Coombs reagent is added. Okay, so that's basically it for that. The other two things on this page are your microangiopathic anemia and macroangiopathic anemia. Infections are a new thing they added. I mean, this is pretty much common sense, but I guess it makes sense to have it there at least, right? Because it is an extrinsic hemolytic anemia. If some infection is causing your red blood cells to be lysed, that's extrinsic. Something outside the red blood cell killed the red blood cell. So we saw one thing, antibodies outside the red blood cell are killing the red blood cell, right? Now you have micro and macroangiopathic. Microangiopathic are going to be cases of DIC, TTP and HUS, which we're going to see later on after platelets, lupus, which we'll mainly discuss in musculoskeletal, and HELLP, HELP syndrome, right? As well as hypertensive emergency. All of these are different case scenarios that can cause microangiopathic anemia, and mainly you'll see schistocytes. So what happens is the red blood cells are damaged when passing through obstructed or narrowed vessel lumina, right? Which is why hypertensive emergency makes sense, right? HELP syndrome makes sense. TTP and HUS isn't exactly hypertensive per se, but those diseases intrinsically cause damage to the red blood cells in the vessels. Lupus also, and DIC. Alright, so when you see the schistocytes, these are all the possible things that it could be that are causing schistocytes to form. Right, those helmet cells, the cells that have just been kind of torn apart. That's what it looks like. It's not a bite cell. A bite cell is G6PD deficiency, and in a bite cell you have like a tiny chunk taken off of the entire red blood cell. In a schistocyte, you grab the red blood cell, you just tore it apart in half. Macroangiopathic anemia is a bigger deal, or bigger as in like size-wise, like something bigger is doing the issue, not a tiny not a tiny thing coming from one of these diseases. So the bigger thing here is your heart valve, right? Prosthetic heart valves and aortic stenosis, which would be an elderly patient, may also cause hemolytic anemia secondary to mechanical destruction of red blood cells. And you again see schistocytes. So here what's happening, and I think UWorld had a question on this too. This probably is it right here. But generally speaking, you'll see a patient who got a prosthetic heart valve placed like a long time ago, and now all of a sudden they're presenting with anemia, and then you do a peripheral smear, you see schistocytes. That's a sign that probably and most likely it's that heart valve itself that's causing schistocytes to pop up. So if we look at these two questions, the first one, 60-year-old African American female is evaluated for fatigue. Past surgical history includes mitral valve repair with the mechanical valve due to severe mitral insufficiency. She has a 30-pack year smoking history and occasionally drinks alcohol. Examination shows pallor. Lab studies show low hemoglobin, high reticulocytes. She's making a lot of new red blood cells, so at least her bone marrow is working. Platelets are normal. Leukocytes are normal. Okay, so she's just low on hemoglobin. Serum chemistries are normal. Peripheral smear shows burr and helmet cells with red blood cell fragments. Okay, what most likely caused her condition? Mechanical trauma. That's it. Red blood cell fragments, burr cells, and helmet cells are consistent with traumatic hemolysis, which can result from microangiopathic hemolytic anemia or mechanical damage. Prosthetic valves produce excessive shear and turbulence. A 34-year-old woman comes to the physician because of recent fatigue and weakness that is exacerbated by cross-country skiing. 4 weeks ago, she was diagnosed with pneumonia, Sputum cultures on Eton agar showed organisms that lacked a cell wall, and you have to remember what Eton agar was for. Physical exam shows conjunctival pallor and cyanosis of the fingertips. Both lungs are clear to auscultation. Which of the following findings is most likely to confirm the diagnosis? Okay, so if the lungs are clear, that means the alveoli are working, gas exchange is working, yet this patient has pallor and cyanosis of the fingertips. Right, cyanosis of the fingertips is generally going to be a sign of some kind of Raynaud stuff happening, right? And we just saw here as well that when the red blood cells agglutinate, they can cause painful blue fingers and toes with cold exposure. Very similar to a Raynaud thing. Right, so they ask you then which of the following findings is most likely to confirm the diagnosis. And if you remember that Eden agar was actually used to grow Mycoplasma pneumonia, that reminds you of cold agglutination and M for the IgM, right? So red blood cells coated with autoantibodies is what's going to confirm the diagnosis of Mycoplasma pneumonia in this patient. Also keep in mind, with Mycoplasma pneumonia, when we were in microbiology, let me actually go back and show you, but one special thing about Mycoplasma pneumonia, it is an atypical pneumonia, so you need to know everything about it. This atypical pneumonia is special because of this thing, the cold agglutination that happens, but also because the patient presents looking fine. They don't look like they're dying, right? But they have pneumonia, which is really bad, right? So they even tell you here, like, both lungs are clear to auscultation. Presentation, generally speaking, is going to be just fine. But a pneumonia patient should look like they're bedridden, right? So if they're not bedridden, that's why this is kind of called a walking pneumonia as well. And if we go back to that, just to revisit it, because it's pretty easy. I think it was the last gram-negative. Yeah, the last gram-negative. All right, so Mycoplasma pneumonia, classic cause of atypical walking pneumonia. Right, it has insidious onset, really quick onset, headache, non-productive cough, patchy or diffuse interstitial infiltrate, occurs frequently in patients under 30 years old. Outbreaks in the military recruits and prisons are very common. The x-ray looks worse than the patient. So the patient looks just fine. Patient doesn't look like they have pneumonia. They're not bedridden. They're actually just walking around just fine. But when you do an x-ray, you're like, holy shit, dude, you have pneumonia. High titer of cold agglutinins from IgM, agglutinate red blood cells. It's grown on Eden agar, and we talked about Eden agar not just here but also in the beginning with basic bacteriology. You can just give macrolides or doxycycline or fluoroquinolone. Penicillin is ineffective because Mycoplasma has no cell wall. Right? No cell wall, not seen on gram stain, is pleomorphic. Bacterial cell membrane contains sterols for stability. You need to remember that. They can give you just this information that the bacterial cell wall has sterols but no cell wall, and you have to know it's Mycoplasma pneumonia. Can cause atypical variant of Stevens-Johnson syndrome, typically seen in children and adolescents. And I've never seen a question on that, but I wouldn't be surprised if it popped up in step 1. And this sketchy micro image here really did a good job showing you everything. Like, this guy's walking around because it's walking pneumonia. He's the referee. And you see how bad the weather looks like it might be, but it's okay. It's not that bad. Right, so basically it looks bad on x-ray, but the patients all look just fine. In fact, you can see there isn't a single person in this image that's dying. And then here all the hockey sticks are kind of sticking together with snow, and that's your IgM, which is actually a pentamer like that. IgM causing all your red blood cells to stick together. So that's your cold agglutinin. Right? Don't eat on ice to remember Eden agar. Right? Really nice. Sketchy Micro has been brilliant for me as far as teaching and just memorizing everything. So excellent time to go back to review things when you see them, right? So that was our basic revision of Mycoplasma pneumoniae, and then you should go check out the other atypical pneumonias as well, like Legionella and stuff, because those guys always present in questions, and pneumonia questions or microbiology questions like that are great because they throw in everything, right? You'll have a question, but all the answer choices, every single bug that can possibly cause pneumonia is given. So at that point, having choices won't help. Like, you just have to know what the bug is, and then you search for it in your choices, not the other way around. All right, so that's all your extrinsic hemolytic anemias, everything that kills red blood cells from outside, and that finishes up all the anemias. We already talked about interpretation of iron studies last time from this table right here, right? Comparing disorders of iron, which is actually much more dense and has much more information than the other iron panel that's given in first aid itself. So we talked about that already. We already got hepcidin, DMT1, and ferroportin, and we understand how iron is handled by our body, right? Really significant to know that. It was in, I believe, yesterday's video or the one before that. So one of the last two videos has this already in there. So I'm going to skip over this stuff right now and jump right down to leukopenias. So there's neutropenia, lymphopenia, and eosinopenia. And there's a very important note here about corticosteroids, so we need to make sure we get it. Neutropenia, and penias in general means you have too low of it. Neutropenia is an absolute neutrophil count that's extremely low, under 1500. Severe infections typically when even lesser than 500. And this can occur just because you're exhausted, like your immune system is exhausted. So causes are sepsis, post-infection, or you're doing chemotherapy where you kill them all off. You have aplastic anemia where you don't even make it. You might have lupus, or you'd got some radiation. Radiation is pretty much an answer to almost everything. And in these case scenarios, if you don't have neutrophils, you will not be able to fight bacterial infections. Lymphopenia is an absolute lymphocyte count of under 1500, but it's under 3000 if it's a child. So for children, it's a bigger limit. Like if you're under 3000 cells per millimeter cube of lymphocytes in a child, that's lymphopenia for them. And lymphopenia occurs in HIV, of course, because you're running out of white blood cells. Your immune system is exhausted in trying to fight HIV, but it keeps mutating. DeJour syndrome, where you don't even have a thymus. Severe combined immunodeficiency, again, where you don't even make lymphocytes. Lupus, corticosteroid, radiation, sepsis, and post-operative. All right. Cushing syndrome and corticosteroids are also responsible for eosinopenia. Absolute eosinophil count of under 30, very low, right? So like 15, 20, 25, something like that. Now, corticosteroids is pretty special. You can see corticosteroids we wrote here and here, right? So corticosteroids cause lymphopenia and eosinopenia. We talked a lot about corticosteroids in endocrine when we first got introduced to Cushing. Corticosteroids cause neutrophilia, though, not neutropenia, right? Despite causing eosinopenia and lymphopenia. So you'll have high neutrophils, but low eosinophils and lymphocytes. Corticosteroids decrease the activation of neutrophil adhesion molecules, impairing the migration out of the vasculature to sites of inflammation. So in corticosteroid use, yes, you do have low neutrophil activity, but you still have a high amount of neutrophils. They just can't get to the infection. In contrast, corticosteroids sequester all eosinophils in the lymph nodes and then blow lymph nodes up. So thereby at the same time killing lymph and eosinophils, right? So that's basically a mass murder of eosinophils and lymphocytes. But neutrophils, they just can't get to the site of infection. But you still have a lot of neutrophils. You don't run out of neutrophils. So you want to make sure you remember that little technical detail about corticosteroids. The last thing on this page is something that's rarely mentioned, but if it ever is, you just want to make sure you don't get confused. And then they mention leukoerythroblastic reaction, which is also pretty interesting. So, neutrophil left shift is an increase in neutrophil precursors such as band cells and metamyelocytes. So left shift is basically referring to this timeline, right? Increasing neutrophil maturity from left to right, and this is your mature neutrophil with multiple lobules to it, right? It's not hypersegmented, but it has multiple segments. And to be entirely honest, this last one does look hypersegmented, but whatever. So you get this. Now, a left shift is just going backwards, so going backwards in time. So you go back to a band cell, and then you keep going back to like a metamyelocyte, myelocyte, stuff like that. Right? And I'm showing you the actual histological images here too. Right? So segmented neutrophil, normal, band cell, metamyelocyte, and myelocytes. So you see that in your peripheral blood. Now, if you do a peripheral blood smear and you see band cells, that's basically a sign telling you that this person is making neutrophils, right? Because nothing went back in time. That's not what really happened. What really happened is that you're making new guys now, and they're slowly maturing. So in your peripheral blood smear, you might find them before they've become fully mature. And once they become fully mature, they'll be active. Usually seen with neutrophilia in the acute response to infection or inflammation. Right, so you're making them. That's why they're showing up. Called leukoerythroblastic reaction, when left shift is seen with immature red blood cells, which means that you not only made new neutrophils, but you're also making new erythroblasts, right? New red blood cells. Occurs with severe anemia or marrow response, right? Fibrosis or tumor taking up space in the bone marrow. A left shift is a shift to a more immature cell in the maturation process. A metamyelocyte is a cell undergoing granulopoiesis, derived from a myelocyte and leading to a band cell. It is characterized by the appearance of a bent nucleus, cytoplasmic granules, and the absence of visible nucleoli. Okay, so that's your entire timeline thing for neutrophils. Now the next page talks about a really interesting, highly tested topic of heme synthesis and porphyrias, as well as lead poisoning. And you do need to know the enzymes, what accumulates, and the whole presentation of such patients. Right, and at the bottom they have a bunch of intermediates. Right, and you can see that heme synthesis first starts at the mitochondria, goes back to the cytoplasm, then to finish it off it has to come back into the mitochondria. So without mitochondria, without well-functioning mitochondria, you cannot have heme synthesis. All right. What else was there? Okay, and then make sure you catch all the names of the diseases, what the enzymes are, what's before them, because that's what's going to accumulate. And this little thing here about glucose actually stopping this, while vitamin B6 needing this. Right. So this first step is very regulatory, and that's very significant. So at the top they tell you porphyrias are hereditary or acquired conditions of defective heme synthesis that lead to the accumulation of heme precursors. Lead itself inhibits specific enzymes needed in heme synthesis, leading to a similar condition. Acute intermittent porphyria and porphyria cutanea tarda. So you have AIP and PCT. AIP and PCT are both autosomal dominant. Right? Autosomal dominant. So that's really easy, and hopefully you won't forget. Like, at least it's not one is dominant, one is recessive. So they're both autosomal dominant. So that basically means that someone in family history should have had similar symptoms. And they can tell you that in a question to help you, right? Like a patient might present with AIP, and they might say like, oh, the patient has port wine urine, psychological disturbance of some kind, polyneuropathy, and the main reason they might have come in was because they had pain in the abdomen. And then they might tell you someone else in the family also had a similar thing. Then you should really start thinking AIP. So let's take a look at lead poisoning first, because this is pretty high yield. Lead poisoning, lead itself affects furochelatase and aldehydrates. So let's go down here and kind of look at them. So furochelatase is all the way down here, and aldehydrate is right here. So aldehydrate is actually the first enzyme that works in the cytoplasm. Right? It takes your ALA, aminolevulinic acid, and makes it into porphobilinogen. Your furochelatase is the last enzyme. If it doesn't do its job of taking Fe, right, furochelatation, so it's basically like it's chelating iron onto the heme. That's basically what's happening with furochelatase. So if you don't have furochelatase activity, the iron won't even combine into protoporphyrin, and you won't make heme. Microcytic anemia, as we saw earlier, just like with iron deficiency, and you see basophilic stippling in the peripheral smear and ring sideroblasts in the bone marrow. And keep in mind, we've been talking about this all of hemonc, that basophilic stippling, right? This is not iron on the red blood cell. Keep that in mind. This is basically ribosomal remnants. Ribosomal remnants. Iron on the red blood cell is a Pappenheimer body, and it does not look like this at all. Right? So this is something that they stress a lot. Ring sideroblast, that is related to iron. So let me just go back to that one more time, because this is actually really important and pretty new, I guess, in a sense. Right here, okay. So they tell you right here, see, ring sideroblast. This is something you would see in a bone marrow, and this is actually excess iron in the mitochondria, because if your furochelatase is not working, all of that iron is not combining with the heme with the protoporphyrin to make heme. Right, so you see this inside the bone marrow smear, along with basophilic stippling in the peripheral smear. What is a basophilic stippling? So if you go to the next page with red blood cell inclusions, basophilic stippling looks like this, and this is basically aggregation of ribosomal precipitates. Right, ribosomal precipitates, and you see this in both cereblastic anemia as well as thalassemia. Right, so lead poisoning, anemyelodysplastic syndrome, and then thalassemia. A Pappenheimer body, which looks like this, and you can find more pictures of Pappenheimer bodies online. This is basically iron in the sideroblastic anemia, but not the same looking. You see how there's only like a tiny bit, as opposed to basophilic stippling. Like basophilic stippling is literally a stippling. It's all over the red blood cell. Where here in Pappenheimer body, you just have like 3 to 4, maybe 5 tiny granules of iron. And you see this in your blood smear. Okay. Now, in the case of lead poisoning itself, they don't mention Pappenheimer bodies at all. So there's nothing about Pappenheimer bodies with lead poisoning. You're just going to have ribosomal remnants on your red blood cell because it didn't develop correctly. And you're going to have ring sideroblasts of excess iron in your bone marrow in the red blood cell because the iron wasn't able to connect. Children, the exposure comes from lead paint usually in old houses, and that leads to mental deterioration. So it's going to show like a reversal in their growth, right? So maybe they were talkative, now they're not talking so much. Maybe they're not as on par as the rest of their classmates and stuff like that. With adults, it causes headache, memory loss, and demyelination. So also a reversal, right? They start forgetting everything, and they can't feel things very well. And this is a question related to lead poisoning and old houses. An 18-month-old boy is brought to the office due to language regression. He said several words at his 1-year appointment, but no longer speaks any words. His moods are also unpredictable, and he throws tantrums. The parents tried to bring him earlier, but they live in an impoverished part of the city and are poor. On physical exam, the boy is quiet and well. Hemoglobin is 9. Which of the following enzymes is most likely inhibited in this patient? And when they ask a question like that, which enzyme is inhibited, you know that because this family is poor and they live in a really poor part of the city, that this is something about heme synthesis and is probably related to lead poisoning. Because this question is not mentioning anything about AIP or PCT, as we're going to see. None of the things that happen in AIP or PCT are occurring in this child. This is very clearly lead toxicity, right? So the enzyme they chose as an answer choice was ALA dehydratase, right? The first one that works in the cytoplasm, but either one would be a correct answer, ALA dehydratase or furochelatase. Lead toxicity is prevalent among impoverished children in urban housing built before 1978. Protoporphyrin 9 cannot incorporate iron, so it incorporates zinc instead, and you find high zinc protoporphyrin. So one of the main reasons I put this question here is because this concept of zinc protoporphyrin, I feel like it was important to know. So when in this last step, the protoporphyrin is unable to take iron into heme, it actually ends up taking zinc and putting it into heme. And zinc doesn't work the same way as iron does, so that heme won't be able to pick up oxygen that well. So if you ever get a question, possibly on NBME, talking about high zinc protoporphyrin, now you know what that's related to, right? The zinc is attached to protoporphyrin, and you couldn't make full-on final heme because the protoporphyrin needed furochelatase activity, and that is related to lead poisoning. All right. So now we can look at AIP. AIP is a deficiency of porphobilinogen deaminase, which works right after ALA dehydratase. Right, so porphobilinogen deaminase right here, it basically, ALA dehydratase makes porphobilinogen, then porphobilinogen deaminase deaminates it, takes off ammonia off of it, and makes hydroxymethylbilane. Right, this step is not going to work in AIP patients. So what happens to them? They have symptoms of 5 Ps, painful abdomen, port wine colored urine, and at this point you might think it's like a renal thing. Then they tell you polyneuropathy, so you might now think diabetes and some kind of renal issue. And you get psychological disturbances, and that's the point where you stop and go like, okay, no, this is more like something related to anemia. On top of that, these patients will have anemia. So although symptoms might match other symptoms of other diseases, not everything has anemia, and this will. AIP patients will have anemia. They're not making enough heme. It can also be precipitated by drugs and starvation. So very important to keep that in mind, right? So the step 1 loves talking about questions where someone was stuck somewhere and couldn't eat for like 24 hours, 48 hours, etc. Whatever the case scenario might be. So starvation can actually lead to activation or precipitation of AIP. The last thing here, and treatment. So this is really interesting, and this is totally worth noting because you can get questions on it. So to treat AIP, if it's like just, this patients with AIP won't have this occurring all the time. That's something weird that you should know. So AIP patients are not always going to have these symptoms. Something usually precipitates it. Otherwise, on other times, they're usually making heme just fine. So when this does happen, you have to give them hemin and glucose to treat them. And how does that treat them? Basically, glucose and hemin both have this weird negative feedback effect on stopping the very first effect that takes place, or very first step that takes place in the mitochondria. You stop the uptake of glycine and succinyl-CoA and making it into ALA. Right, so you will not, okay, cool. You will not even make the first thing, and then things won't back up and things won't stack up, etc., etc., so everything's going to be okay. Right? And when you stop this first step, you just let everything relax, let everything recalibrate itself, and then later on, when they start making heme again, hopefully they're okay. But in all reality, this is just a temporary treatment. There is no perfect cure. You're missing this enzyme, and that's it. That kind of sucks. All right. Last thing, PCT. This is the most common. So just like this had a lot of P's, this has a lot of C's to it. So PCT, cutanea, is related to decarboxylase, right? This is the enzyme right here, uroporphyrinogen decarboxylase. And there's an association with hepatitis C, and it's the most common. What do you see in this? So porphyria cutanea, this enzyme is right here. After the porphyrin deaminase, there's this one step here. Nothing significant that we need to know about it. But this is the last step before you go back to the mitochondria. So this is the step where you have uroporphyrinogen 3 becoming coproporphyrinogen 3. You don't necessarily need to know these names, but these steps can pop up. Like, you can get a question about PCT, and you know that it's PCT, and then your answer choices might be like, okay, so what step is not working? Is it this step from here to here, this step from here to here, here to here, or here to here? And if you see all those answer choices, you can't get lost entirely and not know what to pick. And you would at that point have to pick correctly that it's from Euro 3 to Copro 3. Alright, this is the one that's PCT. And the way I remembered it is because these are both substrates that have the number 3 in it, and PCT has 3 letters, so that's what I told myself when I was studying for step 1, that if I ever do get some kind of answer choice like that, I'll pick the one that has the 3's in it, because that's the one related to uroporphyrinogen decarboxylase. So what do you see in this? You get blistering cutaneous photosensitivity and hyperpigmentation. And it's really weird. That's something that you don't really associate with, like, anemia. But because this has something cutaneous to it, hopefully that'll always remind you the hepatitis C aspect of it, because those are both words that start or have a C in it. And since this is the most common porphyria, you really want to make sure you know it well. The other C thing is consumption of alcohol, right? Exacerbated with alcohol consumption. And alcohol consumption is a pretty big deal for all the porphyrias, but I would most likely directly relate it to PCT since it's the most common. AIP is not that common, nor is it that commonly tested. It is autosomal dominant, and it'll usually be a question about someone who starved themselves, precipitating the whole clinical picture. I wrote here that hepatitis C is usually transmitted parenterally, right? We talked about hepatitis C, B versus C in throughout GIT and of course in microbiology. That hepatitis B is usually between two people. It has to do with sex. Hepatitis C is with the injections, is just taking drugs, IV drugs, right? Look out for patients who are healthcare workers or IV drug users. The patient will present with scleral icterus and jaundice plus a pruritic rash of PCT. And since hepatitis C has a rash and this has cutaneous photosensitivity and hyperpigmentation, the two things go pretty well together in terms of memorization. Patients who received blood transfusions before 1992 may also have Hep C because blood was not screened for hepatitis C before. Okay, so that's pretty significant. Then we have two pretty simple questions right here. So this one over here says, the question stem had a patient with latent TB taking isoniazid and presenting with a history of progressive fatigue and conjunctival pallor. Alright, the question was probably too big, so I described it. CBC shows a hemoglobin of 9 and MCV of 72, so it's microcytic anemia. Bone marrow aspirate under Prussian blue stain shows ringed sideroblasts as iron is transported to developing erythrocytes that cannot form heme. So as granules of iron accumulate around the nucleus. The patient has sideroblastic anemia due to isoniazid-induced B6 deficiency, thereby lowering the activity of allosynthetase. Right, so I told you guys earlier that this first step over here is really significant because of all the things that can regulate it. Glucose and heme inhibit it, and B6 is necessary for it to even work. Allosynthes is inhibited by glucose and heme. But B6 is one of the things you need. Pyridoxine is important for allosynthes activity. And B6 is really crazy because people who are taking medications that make you lose all your B6 are going to have less activity of this. And we can see that usually vitamin B6 questions are almost always going to be something isoniazid related. It's the most notorious medication for causing you to lose vitamin B6. And that's what that question was about. So now we have a question here about vitamin B6 and isoniazid for a porphyria. And we saw more yesterday too. And then when you do your nutrition chapter, you could see with vitamin B6 that there's so many different spots that you can get vitamin B6 deficiency. So you have to know that all of those things can usually be reconnected to isoniazid or some medication and B6 deficiency. Otherwise, normally it's really hard to become B6 deficient. It just doesn't really happen that easily. Last thing here, 22-year-old woman presents with a 5-day history of nausea, constipation, and severe abdominal pain. She also reports anxiety, difficulty concentrating, and tingling of the limbs. So far, we don't have a diagnosis. Up to these 2 sentences, we don't really have a full-on diagnosis. The patient has had many similar events in the past, no medications, tobacco, alcohol, or drugs. Patient is restricting her diet to lose weight. The patient receives IV heme and rapidly feels better. The improvement in symptoms is due to downregulation of which enzyme? And you have to remember synthase, the guy that synthesizes heme, the first enzyme, is the only one that responds to glucose and heme and makes any of these porphyrias feel better. The reason these porphyrias start feeling better is because you stop accumulating the substrate. Right? One of the reasons that you get whatever symptoms you get is because you start accumulating the substrate that won't go into the next step. Right? So that's usually going to be very problematic. And this patient, her starvation, right, because she's trying to lose weight, her starvation was what precipitated AIP. All right, so just if you ever have AIP, your treatment is to basically stop the entire heme synthesis by giving heme and glucose. And that's it. Next page talks about acute versus chronic iron poisoning. And iron poisoning is very common, especially with kids, because it's actually usually a very pink tablet that looks a lot like candy. And if kids find a bunch of iron pills, depending on their age and what you've told them, they might just go ahead and chug a couple, maybe 3 to 5, even more if it's very tasty, and that can be really problematic. So let's look at acute first. Acute has high mortality rate associated with accidental ingestion by children. Adult iron tablets may look like candy, right? So there you have it. Mechanism is cell death due to formation of free radicals and peroxidation of membrane lipids. Symptoms are going to be abdominal pain, vomiting, GI bleeding, radiopaque pills seen on the X-ray, may progress to anion gap metabolic acidosis because of all the vomiting, and multi-organ failure. Leads to scarring with GI obstruction. That's really problematic. And I've always remembered this whole GI thing because the story is also related the other way around. People who have GI bleeding have iron deficiency. So the two things are related in like a weird connection there, right? So someone who's overdosing on iron ends up getting GI bleeding because you need to throw out the iron. All right, so that's kind of something you want to use or whatever works for you really. But make sure you remember that it's going to be someone who just overdosed on a bunch of iron pills either by mistake or for a suicide attempt will end up having GI bleeding. And to fix this, the best thing you could do is, first of all, a gastric lavage, right? If it hasn't been a very long time. Otherwise, you chelate it with anything that has Fe in the name. Deferoxamine, deferoxrox, there's a bunch of D for anything. Fe for iron, right? Chronic, if you have chronic iron poisoning for whatever reason, this can be seen in patients with primary or secondary chronic blood transfusions for thalassemias or sickle cell disease. Primary, hereditary, secondary, hemochromatosis, yeah. Right, so anyone with whatever primary reason of having too much iron or hemochromatosis. Hemochromatosis and sickle cell and all these other case scenarios, these are all scenarios where people are being given blood transfusions on a regular basis. And every time you do a blood transfusion, there's a chance of giving this person too much iron because they might have their own iron and you gave them new iron and all that's going to add up together. So that itself is the mechanism as well of chronic iron poisoning. And what you start seeing there is really different. So you get symptoms that look like hemochromatosis itself, right? So arthropathy, cirrhosis, cardiomyopathy. You had the bronze diabetes, so diabetes mellitus, and hypogonadism, right? All of these are signs that look very much like hemochromatosis. And the real way to treat them is phlebotomy, right? And if they have anemia, though, if they have anemia for any reason, because phlebotomy is only for patients without anemia, if they have anemia for any reason, then of course chelation is something you can do for anyone. Right? Chelation is something you can do for anybody. Now, that finishes everything that was related to anemia. So all things that we're talking about red blood cells are done. The next topic is coagulation disorders, where we now need to understand how our coagulation factors come together and how you're supposed to look at them on labs with PT and PTT. And right after that, we'll jump into platelet disorders, which is a whole different thing, and it's related to bleeding time rather than coagulation. Not the same thing. And I have a bunch of practice questions. Right, so in the next video, I'm going to talk about that. I'm going to talk about the coagulation disorders, platelet disorders, mixed disorders, and we'll look at everything else that's there and do a bunch of practice questions. All right. So thanks a lot for joining, and then I'll be back in a little bit, and we'll move on to that.